cancer pain SIG guidelines, and I think my screen now. So just let me start the screen share. So I hope you can see my slides now. So just type yes in the chat box if you can see my slides, guys, and then we can begin. Okay, great. Yes, thank you, Dr. Sasmith. Thank you. Great. So I'll just make it full screen and we'll go on from now. So last time we have discussed the first part of rather two papers. These guidelines were in four parts, and we have discussed two of them last time. And this is the 54th Pain Journal Club, which is the second journal club of the season 2. And we're going to discuss today the remaining two papers. And pain medicine world over has got a lot of diverse issues, variable standards, different learning requirements, and different offerings. Money and time are two big factors which prevent the pain physicians from learning more and more about this branch. To overcome this, Mumbai Pain School is an initiative of Penmetcha Spine Wellness and Pain Relief Center. And we focus on providing online content using various social media like Facebook, like Instagram. Recently, we also started our Twitter feed. So these courses are mostly online, on demand, and we have both free and paid content. Most of our content is free. We are conducting hands-on workshops regularly, and right now, till now, we have conducted 3 such workshops in the last maybe 4 or 5 months. We are very fortunate to have expert faculties from all over the world. It is said that the best teachers teach from the heart and not from the book. Journal Club is nothing, it's just a club where we critically evaluate the recent academic literature, which is based on a defined subject. Attendee participation is very important. So guys, please type in the questions. Some of you are watching us live on Facebook and some of you are on Zoom right now. So please type in the questions. I'll take up the questions from anywhere, wherever you type. So it's tough to be regular. So just those of you who are here for the first time, guys, please try to be regular. That will be great. The importance of Journal Club is that even the most published textbook or the most popular textbook of medicine, the guy who is credited with it, he also used to hold his Journal Club twice every month. And the purpose was critical evaluation of the academic literature. So time and discipline is extremely important. So I request both the speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I specialize in pain. I work full-time in pain, and I am from Mumbai. But today we welcome two faculties. The first is Dr. Taruna Penmetcha. So please correct me if I have not pronounced it well. So she's the division chair of acute pain and associate program director, pain fellowship in the Department of Anesthesiology and Pain Management at the John H. Stroger Junior Hospital of Cook County, Chicago, Illinois, US. She's also the adjunct associate professor in the Department of Anesthesiology at the Rush Medical College, again in Chicago. So she's also a part of hospital-wide committees, including being the co-chairs and chairs of various committees. And she's got multiple publications in peer-reviewed journals. And she's been recognized for her service rendered to the pain fellowship and patients. And also she's received the Attending of the Year award. So welcome, Dr. Taruna. Welcome to the Journal Club. So we have Dr. Sunny Malik, who is a consultant in charge, Department of Anesthesia, Pain and Palliative Medicine at the Rajiv Gandhi Cancer Institute and Research Center in New Delhi. He's got a number of achievements under his belt. He's been the governing council member of the IAPM, which is a part of the ISSP. He's been the faculty for pain conferences in India for lectures and workshops. He's an active member and presenter at ISSP Delhi Meet, and he's got a lot of academic contributions. But in addition, he's got lots and lots of awards as well. He's been awarded as Susan Raj Young Pain Physician of the Year, Best Emerging Anesthesiologist of the Delhi, also Young Scientist Award. So lots and lots of awards to his credit. He's got also the Excellence in Pain Medicine Award. He's got 2 book chapters and 26 paper publications in various index journals. So welcome, Dr. Sunny.
Thank you. Thank you.
So now let's move on to the first presenter. I will just stop sharing my screen, and I think the first presenter can now start sharing. Dr. Maitri, are you here? Yeah, okay. So Dr. Maitri, I have promoted you to panelist, and I'm also going to make you the co-host so you can start sharing. Yes, you can start sharing now.
Namrata ma'am will be sharing first.
Okay, so he's going to present first. Okay, no problem. So Dr. Namrata, can you present first?
Yes.
Okay.
Part 3 I'm coming.
Yeah, sure.
I'll share my screen.
Sure. So I've already given you the permissions.
Is my screen visible?
Yes. You can begin now. Sure.
Yes.
So before
I'll
let me introduce you. Dr. Namrata Bhagwat is MD in Anesthesiology, and she's done her fellowship in pain and also done her diploma in nutrition and fitness. She is a consultant pain physician at Vatsal Pain Clinic and at Sant Tukaram Hospital in Akola. And she's working as a full-time pain physician. So that's commendable, working in, I think, interior of Maharashtra. So over to you, Dr. Namrata.
We will be discussing ISSP cancer pain SIG guidelines on pharmacological management of cancer pain. So these are into 4 parts. I'll be discussing the part 3. So it is a review of literature. It was published in April-June Journal of 2020 in Indian Journal of Palliative Care, and it was reviewed by Raghavendra Ramajulu Raghu Ita. Pain is often a presenting symptom in cancer. It still remains undertreated despite the guidelines and the availability of opioids. There are guidelines formulated all over the world, but the patient population is different in the Indian context. Also, the conditions of medical practice are different and variable in our country depending on the type of institution or the center one works in. So the aim of these guidelines is to improve the management of cancer pain and to provide the patients with a minimal acceptable quality of life. Methods were a literature search was carried out using PubMed, Medline, Cochrane database, Google Scholar, and Ovid search engine. The studies which were included were those which were published in English language until November 2018. Where evidence was lacking, recommendations were made by consensus, that is, good clinical practice, following extensive discussion among the committee members and considering the results of questionnaire which was circulated during the meeting was made available on the website as well as circulated by email to all the ISSP and Indian Association of Palliative Care members. First, we come to opioids in renal and liver impairment. Coming to morphine, the drug morphine is metabolized in liver into morphine 3-glucuronide and morphine 6-glucuronide, which are excreted renally along with 10% of the parent drug. M6G is a potent analgesic and CNS depressant. M3G decreases seizure threshold. The recommendation is in patients with renal and or liver impairment, morphine should be used in lower doses and at longer dosing intervals. Coming to fentanyl, it is metabolized to norfentanyl and other inactive and toxic metabolites. In liver disease, the metabolism is affected by decreased blood flow rather than the hepatic dysfunction. So the recommendation is that it is relatively safe to be used. Coming to tramadol, it is metabolized in liver to O-desmethyltramadol, M1, which contributes to its analgesic effect. It has high affinity for opioid receptors. Both the drug and the metabolite both undergo renal excretion, and 90% of oral dose is excreted by the kidneys. Therefore, in renal insufficiency, it can accumulate. Significant respiratory depression has been reported in patients with severe renal insufficiency. Methadone, it is primarily excreted in feces. 20% is excreted unchanged in urine. It tends to accumulate in tissues with chronic use, long and variable half-life, and is highly protein-bound. But yet, there is no clinical evidence of accumulation of methadone or metabolites in renal insufficiency. So, it is safe to be used in renal disease, although it is advised to monitor for signs of toxicity. Codeine. Renal clearance of codeine and its metabolite, codeine 6-gluconate, is reduced in patients of RN. It is also metabolized to morphine, and these metabolites again accumulate in renal insufficiency. So the recommendations are that codeine should be avoided in patients with severe renal insufficiency. Buprenorphine, it is metabolized to norbuprenorphine, and it is the only metabolite which has been seen to have analgesic activity. Unchanged buprenorphine is excreted in feces, and the metabolites are mainly excreted in urine. So recommendation generally safe to use in renal insufficiency. Now coming to adjuvant medications. This is the one we discussed for opioids, now adjuvants. So what are adjuvant medications? These are not primarily analgesics, but can exhibit analgesic properties. They are mainly prescribed in mixed cancer pain, such as neuropathic cancer pain, chemotherapy-induced peripheral neuropathy, and metastatic bone pain. They are prescribed either with opioids or by themselves. The examples are antidepressants, anticonvulsants, corticosteroids, radiotherapy, bisphosphonates, RANKL ligand antagonists, ketamine, anticholinergics, somatostatin analogs, etc. Coming to the first adjuvant medication, that is antidepressants. These are prescribed along with opioids, although a constant vigil should be maintained for serotonin syndrome when used in conjunction with serotonergic medications. Which will, so if somebody gets serotonin syndrome, then there will be myalgia, shivering. So it can even range to severe symptoms, including death. Started at lower doses and increments in dosage are done once in 5 to 7 days. Although, and caution applies to all of the antidepressants, that is ischemic heart disease, conduction defects, closed angle glaucoma, and prostatic enlargement. You have to have caution in them. Adverse effects include sedation, dryness of mouth, urinary retention, constipation. Venlafaxine in particular can cause ventricular arrhythmias in an established heart disease. These are the most commonly used antidepressants. So tricyclic antidepressants and SNRS. In tricyclic, mainly amitriptyline has been studied. Imipramine, desipramine, nortriptyline, duloxetine, venlafaxine are also available. So amitriptyline's number needed to treat is 3.6 and NNH is 13.4. Number needed to treat is how many patients need to be treated before the patient experience an additional bad outcome, in this case pain. NNH is how many patients need to be treated so that one additional patient has some adverse effect. So the safe profile would be lesser the NNP and higher the NNH. Coming to other adjuvant medication like anticonvulsant, pregabalin and gabapentin are the most known anticonvulsants. They act by modulating the alpha-2 delta subunit of calcium channel in the dorsal horn of spinal cord. What these do is these decrease the release of substance P and glutamine. Pregabalin has an additional anxiolytic activity. Number needed to treat for pregabalin is 7.7, while NNH is 13.9. And that for gabapentin, NNT is 6.3, so low, and NNH is 25.6. Bone pain. Metastatic bone disease is most commonly seen with specific cancer types, notably those arising from breast, lung, kidney, prostate, as well as multiple myeloma. Pain is a debilitating symptom with skeletal-related events, which lead to loss of mobility, increased dependency that affect the health-related quality of life of the patient. In such cases, bisphosphonates and receptor activator of nuclear factor kappa B ligand, that is RANKL antagonists, are bone-specific agents which are aimed at relieving bone pain and hypercalcemia and reducing the incidence of skeletal-related events. And the other is external beam radiotherapy and radioisotope. These also play an important role in the management of metastatic bone pain. Bisphosphonates and RANKL antagonists, specifically denosumab, both of these act on osteoclasts. Bisphosphonates induces apoptosis of osteoclast, while RANKL antagonist They prevent the activation and survival of osteoclast. As a matter of fact, both of them act on inhibiting the resorption of bones. Both are beneficial in preventing pain by delaying the onset of bone pain, rather than providing analgesic benefits once it sets in. Both are generally well tolerated. Coming to zoledronate, which is a part of bisphosphonates, there may be episodes of transient increase in bone pain, fever, and myalgia-like symptoms which peak in 24 to 48 hours and then resolve within 72 hours. Renal dysfunction associated with zoledronate requires regular evaluation of creatinine or creatinine clearance. Osteonecrosis of the jaw is a complication seen with both therapies. Hypocalcemia is seen more with denosumab. Regular monitoring of calcium level is needed. Vitamin D and calcium supplement is strongly advised. Again, this is a table where bisphosphonates and rank L antagonists are given. So, best bisphosphonates studied in breast cancer, zoledronate. Again, prostate cancer, zoledronate. Other solid tumors are as per the primary malignancy. Multiple myeloma, zoledronate and pamidronate are equal efficacy, and zoledronate superior to clodronate. Rankel antagonist is just one used here, denosumab. Now coming to radiotherapy. So radioisotopes provide complete reduction in pain over a period of 1 to 6 months, but severe adverse effects such as leukocytopenia and thrombocytopenia are associated. Except for radium, the rest have shown minimal benefits. And radium-223 has been shown to improve SRE and also prolong survival. Single dose of 8 grays give profound pain relief in majority of uncomplicated metastatic bone pain. Again, a single dose of 8 grain can also be considered for re-irradiation if there is recurrence of metastatic bone pain. RT is the first-line treatment in metastatic spinal cord compression. The ideal effective dose schedule is 20 grays in 5 fractions or 8 grains in 2 or 1 fraction. Again, the adverse effects is leukocytopenia and thrombocytopenia. In metastatic spinal cord compression, steroids are to be started immediately after the diagnosis has been established. Dexamethasone being the most commonly studied drug. Now, they are quite high doses which have been studied. So, the evidence on loading dose is limited, although it ranges from moderate, that is 8 mg per day, to as high as 36 to 96 mg per day, preceded by bolus of 100 mg IV. Surgery should be advised in patients with spinal instability and then the recurrence of pain after RT. Now, coming to corticosteroids, we all know corticosteroids have anti-inflammatory properties and they exert their effect on pain and nociception. So, the arachidonic acid metabolites, all they culminate into various inflammatory mediators. Corticosteroids stop all of them. So, what happens is because of that, there is decrease in capillary permeability and reduce in the edema. Hence, they are used in clinical situations of inflammation and edema, especially in confined spaces, including intracranial, spinal, pelvic, or retroperitoneal spaces. Also used in the relief of pain from space-occupying lesions of brain, spinal cord, nerves, liver, and soft tissue. Dexa is the most studied corticosteroid and it has the least mineralocorticoid activity, and due to its long duration of action, it also can be used once a day. Now, these do not improve opioid analgesia or they do not reduce the consumption of opioids in advanced cancer patients. And overuse of them may lead to increased susceptibility to infection, hyperglycemia, insulin resistance, proximal myopathy, catabolic effects, skin changes, and adrenal insufficiency. Advanced cancer patients are particularly vulnerable, hence while prescribing, the risk-benefit balance should be considered. Coming to ketamine, it is a dissociative anesthetic. We all know it is an NMDA receptor antagonist. The indication is when pain is unresponsive to opioids or when opioid tolerance occurs. But the use of ketamine is restricted because of its side effects, which include psychomotor retardation and hallucinations. Some studies report the absence of sufficient evidence of benefit of ketamine as an adjuvant in cancer pain. Anticholinergic and somatostatin analogs. Now, malignant bowel obstruction can lead to colicky abdominal pain that can be very debilitating. Anticholinergic drugs reduce the propulsive gut motility and decrease the secretions, thus reducing the colicky pain. Octreotide is a somatostatin analog that inhibits the secretion of gastric, pancreatic, and intestinal secretions and reduces the GI motility. A study concluded that the combination of octreotide with an anticholinergic can be very effective in the symptom management of inoperable bowel obstruction in terminal cancer patients. The conclusion is, this article emphasizes the importance of adjuvant analgesic medications in the form of antidepressants or anticonvulsants to treat cancer neuropathic pain. Even radiotherapy plays an important role in the treatment of bone mets. Denosumab and bisphosphonates also play an important role in skeletal metastatic pain. Corticosteroids help reduce the edema and inflammation. Then there are some recommendations which are given. So we have sorted out the level 1 evidence and grade 1 recommendations and the other ones. So what we have learned till now is the same what has been given. So antidepressants, anticonvulsants should be used to treat neuropathic cancer pain, and the dose should be titrated according to clinical response and side effects. External beam RT should be offered to all patients with painful metastatic bone pain. Denosumab should be considered as a valid alternative to bisphosphonates for the treatment of patients with or without pain due to metastatic bone disease from solid tumors. Radioisotopes should be considered for short to medium-term pain relief, keeping in mind the side effects. Antidepressants or anticonvulsants should be used to treat neuropathic cancer pain, and the dose should be titrated according to clinical response and side effects. Again, this has been repeated. So, radiotherapy and antidepressants and anticonvulsants. So, these are all 1A, 1B recommendations. And coming to 2A and class 4 level of evidence, that is grade B and grade C recommendations. So grade B, steroid should be started in patients with metastatic spinal cord compression. Bisphosphonates to be considered as a part of therapeutic regimen for the treatment of patients with metastatic bone pain. Grade B, but yet they can be started. Opioids should be used with caution in patients with renal and hepatic impairment. This is grade C recommended. Codeine should be avoided in patients with renal impairment. Limitations accepted are none, and critical analysis subject to availability of opioids. Although now opioids are available everywhere, yet in some interiors it becomes a difficulty. Even if it is available, sometimes there is no stock of opioids. So that can pose a problem. No elaborate comments on opioids and hepatic impairment. There is no mention of management of headaches due to raised ICT in brain tumor, and no mention of NSAIDs, toxins, or paracetamol. The take-home message is a pain physician ought to make optimum use of available opioids, adjuvants, RT, and other drugs in management of cancer-related pain management. The cancer pain should not be left undertreated for fear of renal impairment and hepatic impairment complications. Hence, one should be well acquainted with the guidelines. Thank you.
Thank you, Dr. Namrata. I will now request Dr. Maitri to start sharing her screen, and we go on to the second presentation. We'll take the questions together in the end. Guys, if there are any questions, you are free to type in the question and answer box. I have answered one, I have received one more. So from Dr. Islam, we'll take your question. So please type in the chat box or in the Q&A option, which is given here.
Is the slide visible?
Yeah, I can see your screen. Put on your CV slide, I'll just introduce you. So Dr. Maitri Shah is fellow in pain medicine at the Department of Pain Medicine, DYPU University School of Medicine in Navi Mumbai. So over to you, Dr. Maitri.
Hello, good evening, everybody. Today I'll be presenting on the ISSP and Special Interest Group Guidelines on Pharmacological Management of Cancer Pain, Part 4. That is the last part of this session. It is taken from the Indian Journal of Palliative Care from the month April and June 2020. The authors of this article are Arif Ahmed Sir, Raghu Sir, Parmanand Jain Sir, ETA. Introduction. The WHO analgesic ladder might leave 12% of the patients with inadequately managed pain. Recommendations to use interventional management. Number 1, conventional therapy fails to offer adequate benefits or causes undesirable side effects. Second, cancer pain still remains undertreated despite the presence of guidelines and availability of opioids. These guidelines are developed to improve the management of cancer pain and to provide the patients with minimal acceptable quality of life. Methods used. Literature search was done on PubMed, Medline, Cochrane database, Google Scholar, Ovid search engine. There is a limited amount of high quality evidence for interventional pain management techniques to manage cancer pain due to the difficulties in performing randomized controlled trials in this therapeutic area. Following are the prerequisites and selection criteria for interventional pain techniques. Number one, standard treatments such as systemic drug therapy fail to offer adequate pain relief or cause unbearable side effects. Second, adequate counseling of the patient and patient care provider about the procedure, including risk, benefits, expenses, etc. Informed consent. Fourth, after ruling out other causes of incomplete or inadequate analgesia. Fifth, expertise performing the procedure is available. Sixth, there is no contraindication to the planned procedure otherwise. Commonly used interventional procedure. First one is neurodestructive procedures for well-localized pain syndromes. Number one, head and neck, peripheral nerve block. Second, upper extremity, brachial plexus neurolysis, intrathecal neurolysis. All these blocks we'll be discussing in the later slides and details. Third is the thoracic wall, epidural neurolysis, intercostal neurolysis, etc. Upper abdominal pain, visceral pain basically, celiac plexus block, splentic neurolysis, pelvic pain, superior hypogastric plexus block. Sixth, rectal pain, intrathecal neurolytic saddle block, superior hypogastric plexus block, ganglion impar block, unilateral pain syndromes, chordotomy. Other are radiological interventions, that is percutaneous, vertebroplasty, kyphoplasty, etc. Neurostimulation procedures for cancer-related symptoms and regional infusions. Moving on, commonly used agents in interventional procedures. Number one, absolute alcohol diluted to 50% alcohol, 6% aqueous phenol, and third, phenol and glycerin. Study comparing the effectiveness, duration, benefit, and complication profile of the agents showed no difference in the pain outcome, complications, and duration of benefit. Thus, it is recommended the choice of neurolytic agent can be appropriately left to the clinical judgment and the availability of the expertise. Next, celiac plexus neurolysis. It is used in pain arising from cancer of pancreas, liver, biliary tract, kidney, ureter, spleen, bowel up to proximal third of the transverse colon. Neurolysis is done using the landmark technique, fluoroscopy, endoscopic ultrasound, transabdominal ultrasound, or CT guidance. There is effective prolonged pain relief and lowering the dose of opioid with reduced side effects and improved quality of life after neurolysis. Evidence available is 4 randomized controlled trials, few observational studies, 2 meta-analysis, and Cochrane review. Next is splanchnic nerve neurolysis, an alternative to celiac plexus for relief of pain from abdominal cancers. Evidence available is 1 observational study and 3 retrospective studies. Evidence of RFA radiofrequency ablation splanchnic nerve neurolysis. We have 1 retrospective study for that, and combination of radiofrequency lesioning with neurolytic block can be used for enhanced effect. Moving on, superior hypogastric plexus block, used for management of pain arising from pelvic organs. Evidence available is 3 observational studies and 1 randomized control study, 1 randomized control trial. Neurolysis can be done under fluoroscopy, CT, or ultrasound guidance. The advantage of supine position and less chance of vascular injury when using the ultrasound. Next, ganglion impar block, management of pain arising out of perianal structures. Few case series are available as evidence. The block can be performed using the aid of ultrasound, fluoroscopy, or CT. It can be combined with superior hypogastric block for combined pelvic and perianal pain. Next, intercostal neurolysis. Intercostal neurolysis or radiofrequency ablation has been used for chest wall pain from cancer. Evidence we have is observational studies and some case series. Next is epidural neurolysis. Evidence is again limited with few case series, rarely attempted nowadays, as much safer options such as intrathecal delivery of opioids or other agents are available. Next is brachial plexus neurolysis. Brachial plexus neurolysis has been useful for relieving intractable pain arising from the tumor compressing upon it. It leads to loss of motor function of the limb and should be attempted very cautiously. Alternative to brachial plexus neurolysis can be continuous brachial plexus block with a catheter, single shot injection with local anesthetic along with a corticosteroid or a liposomal bupivacaine. Third, intrathecal selective sensory neurolysis. In this, the motor function is intact. Intrathecal neurolysis. Evidence: few old studies or recent case reports, rarely attempted except in specialist centers, as much safer options are available. The chemical agents used are: number one, alcohol with concentration of 50 to 100%. Alcohol is a hypobaric solution, so the affected site is positioned up at 45-degree angle. Second, phenol 6 to 12%. It's hyperbaric. The affected site is positioned down at the 45-degree angle. The limitations are inadequate pain control with progression of disease, limited duration of effect, motor weakness of lower limb, and rectal or bladder sphincter dysfunction. The procedure is helpful in patients with less than 1 year of life expectancy with well-localized intractable pain, and also in somatic more than visceral pain. Next, epidural, intrathecal, or intraventricular opioid infusions. This is used for pain which is not controlled by medications given systematically. Patients have undesirable side effects at doses required to provide analgesia. The evidence available is 2 randomized controlled trials which suggested improved analgesia and prolonged survival in patients receiving neuraxial opioids as compared to the conventional medical management, and a high quality review suggested similar efficacy of opioids delivered through intrathecal, epidural, or intraventricular route. There are different types of pumps ranging from percutaneous catheter to fully implantable programmable pumps available. The benefits are less incidence of infection with implantable, low maintenance. Cost of the therapy of implantable pumps is less than non-implantable device if the use is more than 3 months. The intractable medication can be delivered via an external pump or an internal programmable pump. Opioids used are morphine for patients who has responded partially to systemic morphine or are limited by side effects. Patients who fail to respond to opioids, other medications such as LA, clonidine, ziconodine can be used and have shown good results. The intervention should only be undertaken in patient with expertise in this technique with aftercare. First, now life expectancy is less than 3 months and epidural route is preferred. The epidural catheter should be placed percutaneously and fixed at skin or by subcutaneous tunneling with medication being delivered through a programmable pump or syringe driver. The patients, if ambulatory, can be managed as outpatient also. This is the pump which we have been using. Second, if the life expectancy is more than 3 months, an intrathecal route is preferred. The intrathecal medications can be delivered via an external pump or an internal programmable pump. The programmable pump needs refilling after few weeks or months. Patient need to be in close follow-up with managing specialist. Pain in the head and face, intraventricular opioids can be administered via implanted pump and catheters. Next is cementoplasty. Cementoplasty, injections of bone cement, including vertebroplasty in the vertebral body, kyphoplasty, sacroplasty in sacrum, acetabuloplasty in acetabulum, and osteoplasty, weight-bearing bones. Cementoplasty includes injection of acrylic bone cement into the malignant bone cavities to either relieve the pain or stabilize the bone, or both, and sometimes considered after the RFA of tumors. Kyphoplasty involves the restoration of the original height of the vertebrae by inflating a balloon inside the cavity of the vertebrae and filling up the space treated with bone cement. The evidence is few observational studies and case series. Benefit rapidly and significantly reduce the PI, reduced the requirement of opioids and functional disabilities. Side effects, cement leakage, and most of these are asymptomatic and less commonly associated with kyphoplasty. Example, in patients with sacral metastasis, the injection of cement into sacrum or pelvis bone has shown to reduce pain and improve mobility. Concluding, the ISSP pain and SIG guidelines on interventional pain management for cancer patients in adults emphasize the importance of interventional pain management treatment as an adjuvant therapy for pharmacological cancer pain management. In this table, they have shown that neurolytic celiac plexus block and epidural, intrathecal, or intraventricular opioid infusion are level 1 evidence. Choice of again, the second point, choice of neurolytic agents should be based on good clinical judgment and availability of experts, and patients whose pain control is poor despite optimal pharmacological therapy should be referred to specialists trained in interventional pain management. These have level 2 evidence. And vertebroplasty should be offered in patients with uncontrollable bone pain with malignant vertebral collapse, where expertise is available, has level 3 evidence. Critical analysis. No single interventional method has shown superiority over the other as been discussed in terms of Indian population. Second, information about combination of intervention with that drug therapy pre and post interventional procedure hasn't been mentioned. Third, no data mentioned about a guideline after a failed intervention. Next, use of interventions in early stages of cancer pain management is not mentioned or discussed. Concluding, the guidelines on management of cancer pain in adults will help pain specialists, anesthesiologists, palliative care specialists, and others who are involved in cancer pain care must use interventions in conjunction with patient assessment and may be individualized as per patient need for safe management of cancer pain and to provide the patient minimal acceptable quality of life. Thank you.
Thank you, Dr. Maitri. Now it's over to the faculties to conduct the session further. Dr. Sunny and Dr. Taruna.
I would start. First of all, I do want to congratulate both the presenters. They did an excellent job with the reviews. And I also want to congratulate the faculty, that is the organizers that are hosting this journal club. It's a very big initiative to work with the guidelines and to review all the recent literature. And I appreciate the opportunity to be on the faculty. First of all, what is minimally acceptable quality of life? For any human being, I think we have to think about cancer pain management as a quality of life is the biggest thing. So a lot of times when oncologists are treating these patients, the main goal is to treat the cancer, and pain and symptom management takes a hind seat. So it is important for us as interventional pain physicians to be proactive and be working with our colleagues, both the oncologists as well as palliative care colleagues, and informing them about what kind of options we have in managing the cancer pain. And although the interventional pain management is thought to be as the last resort, it should not be considered as the last resort. There are patients in cancer pain, it's not just the tumor itself that causes the pain, but because there may be management of cancer that can cause neuropathy related to radiation and chemo, metastases can cause pain. There can be pain because of compression of the neighboring structures with the visceral compression, nerve compression, spinal cord compression. So it is important for us to see what patients can benefit from what kind of interventions at an early stage. While you're managing the medications at the same time, think of options which can be managed if it's local pain, intercostal block for patients with rib fractures or vertebral compression fractures or long bone tumors which may need stabilization versus you can do radiofrequency and vertebroplasty or cementoplasty for those patients. So it is important to think ahead before the pain becomes a major issue. The things, I saw a question regarding what are the safest drugs for liver and hepatic failure. Can we talk about it in a few words? So it is important to understand that there is nothing that I would say is totally safe. It is important when you're managing these patients, we cannot let them suffer in pain because they have liver failure or renal failure. It is important to start slow, start low, and increase the interval between the dosing so there is enough time for the drug to metabolize, for the drug to be excreted. So if we look at the safety profile amongst all the narcotics we have, I know in India we are using morphine quite a bit. I'm not sure if it is only immediate release morphine or if it is extended release also. But if you're using morphine, then we need to be relatively we need to be careful because you have to use the lowest doses possible to manage the pain and titrate slowly, titrate very, very slowly. So you are giving enough time for the drug to be excreted. If you're using fentanyl, fentanyl is relatively safe, both for liver failure patients as well as for kidney failure patients. But the preparation of fentanyl makes a difference. IV fentanyl versus using fentanyl patch, there is a difference because fentanyl patch is a depot preparation and it stays in the lipid tissue in the body. So if you are titrating it, slowly titrate, so patient has time to adjust to the dose, and then give it time, because you cannot dialyze the molecule, you cannot dialyze fentanyl patch that is not in the bloodstream. So be careful with fentanyl when you're titrating it. Methadone, it is relatively safe drug in renal failure. It is not excreted to the kidneys. Most excretion is through the feces. So it is safe for renal patients, but for liver patients, we have to be careful with methadone. It has an extremely long half-life, and also it has a lot of metabolism, which is through P450 enzymes. So it can accumulate, it can cause a lot of side effects, it can have a lot of interactions. So it's not very safe drug for liver patients. If there is no choice and you have to use methadone, then go with the lowest dose as possible. The methadone is not an equi-analgesic medication. You know, if you are using at a higher doses of opioids and you're trying to put patients on methadone, start very, very low. I think that's pretty much about the medications that I would say. I know that duloxetine was mentioned in one of the tables. It is a good medication to consider for patients who have neuropathic pain that is related to cancer and chemotherapy. That's one drug that has shown benefit in literature with the chemo-related neuropathy. So it is a good drug to use. It is an SNRI. As long as you're careful with the side effects, it's a good drug to use for chemotherapy patients. Regarding the procedures, I think in what I see here, a lot of patients from different backgrounds or the family members with, let's say, Indian patients, they try not to involve the patient in the care. They try not to give a diagnosis of cancer to the patient. But I think it is important as pain physicians to involve the patient in their own management. The patient can understand what the disease is. It is important for the patient to communicate and tell you where the pain is and how to manage. A lot of times the patients are not the ones, but the family members are communicating because they're worried about the patient knowing the diagnosis. So try to see if the patient is willing to, if the family members are willing to involve the patient in the management, and that makes a big difference. I think that's pretty much I have to say, Dr. Malik.
Yeah,
Yes.
Yeah, Dr. Malik, you can go on.
A very nice presentation from both these speakers. Siddharth, you are doing a wonderful job teaching us also and all the young pain physicians, and it is a continuous process for I think more than 1 year. Thank you for giving me the opportunity as a faculty at this Mumbai Pain School. I would like to add that guidelines are usually made for the pain physicians so that they can follow them easily. But this cancer pain patients, I have been doing this purely onco pain management for the past more than 6 years. And what I found that it is like morphine. The dose is to be individualized according to the individual, tailored according to the needs. So cancer pain is totally different. We will follow the guidelines as a pain physician so that every patient can have access to pain treatment, but we have to treat patient as a whole. So what we have to do, first, we have to be well versed with the World Health Organization analgesic step ladder. And in this, apart from morphine or fentanyl, we have to be well versed with the role of the adjuvants, especially in cancer pain management, because you will not get a patient having purely nociceptive pain, purely neuropathic pain. You will get a mixed variety. Many a times I get patients, like recently I came across a patient who has been treated with urinary bladder cancer, and then also as a survivor, she is having pain. So there is a role of sensitization also in such patients. So role of adjuvants is very important. That includes these anti-neuropathic medications, antidepressants, these bisphosphonates, bone strengthening agents. Apart from that, local anesthetic patches and IV local anesthetics are also useful for this cancer pain management. Now, third is the role of the follow-ups. Follow-up is very much needed when you are prescribing opioids for these cancer pain. Next is talking to the family. You have to first listen to the patient. I always say listen, listen, listen. Listen for half an hour to the patient, the family members. You will find out what is the psychological burden, who is the decision maker. Then you have to talk with the treating oncologist also before starting any treatment for cancer pain patient, so that you can prognosticate, you can define the goals of care, you can get the ECOG scoring of the patient. So this is very important, talking to the patient, the family, as well as the treating oncologist. Now coming to the interventions part. Interventions definitely should be performed, especially for the visceral malignancy pain, the celiac plexus or the superior hypogastric plexus or splanchnic neurolysis with radiofrequency ablation. They should be done at the earliest and can be done at step 1, step 2, or step 3 according to the expertise of the pain and the palliative care specialist. But the WHO guidelines and the validation reports, they always say that 70 to 75% of the patients, they benefit with pharmacotherapy, and the refractory patients, the intervention should be planned for those cases, and they help to supplement the analgesia. So pharmacotherapy has a major role and it has to be continued till last breath of the patient. This is very important. Next is, we always talk about the opioids. The correct titration of the morphine is very important. You have to start from low dose. You can increase the interval as said by the other faculty, that in case of renal impairment or hepatic impairment, you can increase the time period of the dosing and go slow. Do regular follow-ups if you are treating the patient with oral morphine, and on regular follow-ups, see the pain diary and increase the dose by 20 to 25%. And always counsel the patient for cancer pain that we cannot treat it, but we can be able to control it. And it is our target that we can achieve, by this we can achieve a cancer pain management of up to 50% so that the patient can sleep overnight. Sometimes you will get patient having severe pain with a VAS score of more than 7, and the breakthrough pain episodes are more than 7 per week. For those, you should have a facility for admission, and in those cases, go for the IV or the parenteral dose titration of morphine, because the bioavailability is better as compared to the oral morphine. Next is, we always talk about the cancer pain, but there is also the symptom burden which is associated with cancer pain. Patient comes to you, he says he's again having breathlessness. You cannot say that I treat only pain. You have to you have to control the symptom burden also. Symptom burden includes, when there will be pain, there will be nausea, there will be vomiting, then cachexia, weight loss, loss of appetite, plus patients are bedridden, ECOG score 4. So they have constipation. In the geriatric age group, the motility gets decreased. Apart from that, you are giving opioids. So there is constipation. After some period, sometimes the patient gets spurious diarrhea for 2 to 3 days. So these things to be taken into consideration too while treating the pain patient, especially managing the cancer pain. Comorbid status also have a role. Patient has hypertension. You have started these duloxetine and amitriptyline. The BP can shoot. So these things also should be taken into consideration. Moreover, especially for the abdominal malignancies, there has been found, and it has been reported in the PET scans and the CT scans also, that the disease has spread to the retroperitoneal tissue. The lymph nodes are studded with tumor. Moreover, they are impinging over the duodenum or the gastric outlet. So these patients can have gastric outlet obstruction or subacute intestinal obstruction type of features. So while giving these opioids, you need consider these things also. Lastly, dose conversations are very important. You titrate the dose with morphine, and you should know the EQ analgesic tables too if you want to shift the patient to methadone or the transdermal fentanyl patches. And lastly, we always talk in the slides about the total pain concept. So the psychological burden, especially in the cancer patients who are bedridden, they are dependent on the family members. So the social isolation part and the psychological burden is very high. That's why listening to the patient, psychological counseling, and a team approach is very important apart from following these guidelines. Over to you.
Great. So let's take some quick questions which are still there. Dr. Islam is asking, can steroids increase the metastatic area? Any comments, Dr. Sunny? Dr. Taruna?
Steroids are one of the adjuvants, oral steroids or the IV steroids, which are used for the cancer pain management, as well as they are used by the medical oncologist also for controlling this chemotherapy induced vomiting, and certainly is sometimes for the treatment part also in lymphomas as well as the multiple myelomas. So there is a doctrine of double effect, especially in palliative care. Everything has two parts. It is a seesaw-like situation. One is the good part and one is the side effect or the evil part. So your moral duty is that the risk-benefit ratio should be taken into consideration. Like, for example, you take a cab or you drive a car knowingly that accidents happen on road, but then also you are using a car. So it's like this situation. So the benefits are, for example, it is used for emesis, for control of the nausea and vomiting, which is not controlled by the regular antiemetics like ondansetron or metoclopramide. Moreover, these steroids, they give a feeling of goodness to the patient. They decrease the fatigue of the patient. Plus, for the metastatic bone pain, they are anti-inflammatory. So the good effects are more. However, it has been found, it has been reported that if the patient is on long-standing these prednisolone-like drugs for the inflammatory conditions, no doubt some leukemias they have been reported. But according to the doctrine of double effect, definitely the cancer pain specialist as well as the medical oncologist, they are using these oral steroids. I am also using, and they are doing wonders for the patients.
Great. Let's move to the Dr. Taruna, you want to add something?
No, I think Dr. Malik explained it pretty well. And a lot of times it is important to have the idea. A lot of times you just cannot manage the cancer pain patient on your own. You have to understand what the oncologist is doing, what is the role of palliative, what is the patient's wishes and the family social circle around the patient, what is his social support. So all that comes into play. And definitely regarding the steroids, it is a drug that you have to weigh the risk and benefits like any other medical management that you will do in cancer pain.
Great. Let's move to the next question. This is from Dr. Kritika. She's asking about intrathecal neurolysis. So she's asking how performed for. So I think this is a very technical question. So thoracic intrathecal neurolysis is, very few people are actually doing it. Dr. Sunny,
I am not fond of doing intrathecal neurolysis. I will go for the pump implantation and the titration of the doses of the morphine only.
Yeah, I totally agree. Intrathecal and epidural neurolysis, it is technically challenging because of the spread of the drug. And if you have a patient where you are looking at end-of-life patient who can survive with motor deficits or sensory deficits, it is just an older procedure that is not done anymore because you have much more targeted therapies and you can use intrathecal pump. Sometimes even DRG and other therapies which are much more targeted compared to what you would achieve with neurolysis. The neurolysis, you would probably go more for celiac plexus block, hypogastric or ganglion impart, maybe intercostal nerves where you can do more targeted neurolysis and get better control. So those are more preferred options than epidural and intrathecal neurolysis.
Moreover, it is very difficult to make them understand that certain side effects can happen, and then also we are doing this thing, even if the patient is bedbound and not able to do self-care.
True.
Yeah, agreed. But having said that, there's still a couple of guys who are doing quite a good number of cases, especially in the UK also. And I think one of our professors in Tata says that he, from Tata X from the Tata Cancer Hospital, they also say that we do a lot of used to do, or we do a lot of intrathecal neurolysis. But I also agree to what Dr. Sunny and Dr. Taruna have said, that it's
he is a pioneer of intrathecal neurolysis.
Yeah. So no, in UK, if you see a lot of you get some literature at least now, and I'll try to invite somebody to speak on this, so that at least some understanding is there, and then you can decide for yourself how much risk you want to take. Okay, great. So this brings us to another question, which is I think this is already answered. Has subcutaneous route administered fentanyl have any advantage in real? No, in fact it's not advantageous. It's I repeatedly say that if you I find the patches quite shaky, because especially in a dwindling or in a very uncertain situation wherein the renal compromise can happen anytime, or the organ functions can deteriorate very fast, because once after I remove the patch, the drug is going to continue to diffuse into the stream for quite a long time. So I think it's a shaky wicket. So I will not like to any other comments are welcome.
Now, if you want to shift the patient to the equianalgesic dose of the fentanyl patch, one thing which can be done, what you do not transfer to the whole dose of the patch. You keep it a bit low and add on normal release 10 milligram morphine to cover the other requirements. Like for example, if the patient is taking around 60 mg of this oral morphine equivalent, so 60 mg morphine is equivalent to the 25 microgram per hour of fentanyl patch. So this thing can be done, that you can shift the patient to 12.5 microgram of fentanyl patch, and the other parts, that 30 mg morphine, you can give 10 mg normal release in a thrice daily dose also. So
yes,
this also helps.
Yeah,
you will get a baseline infusion.
Start at the lower dose. Yes, whenever you're switching, you start at the lower dose, because that's the benefit of the rotation, and also you are wanting to exploit that by reducing the side effects while trying to minimize the tachyphylaxis or the response, which is
definitely
One thing about the fentanyl patch, I think we use it quite often for patients who have GI malignancies or do not have or oral malignancies, or patients who are not able to use anything by the PO route. So that's where the fentanyl patch is beneficial. And for any drug, when you're doing a change from you're rotating an opioid from one opioid to another, always go with the 2/3 of the calculated dose. And then rest can be added on as immediate release. That way, you do not know how the patient is going to respond, because the pharmacokinetics and pharmacodynamics of the drugs are different. So it is always important to go with the 2/3 of the calculated dose and not do an equianalgesic 1:1 conversion. Always do immediate release to get the patient comfortable.
Yeah, great. So this brings us to the last question. This is from Dr. Sushil. So brachial plexus involvement, how do you manage if it is not responding to the neuropathic drugs?
Brachial plexus pain, it is not an easy pain to treat. Even with spinal cord stimulation, sometimes we are not able to get a good response. The only thing that has, you can use opioids, you can use neuropathic pain agents, ketamine plus and minus. Methadone is a good agent, good opioid to use in pain that is more neuropathic in origin because of its NMDA properties. It is an NMDA antagonist on top of its mu agonist properties. So it's a good agent to try for neuropathic pain. But some centers do DRES lesioning, dorsal root entry zone lesioning, to help with the brachial plexus pain. But those are the options. Medically, you have to optimize your adjuvants that are targeted towards neuropathic pain management. Ketamine infusions may provide relief, but not long-lasting. Short-lasting IV lidocaine infusions can be beneficial. And interventional management-wise, there is stimulators can be tried, dorsal root ganglion stimulation can be done, and then obviously dress entry zone lesions, which are more invasive management.
Great. So there is one comment from Dr. Renuka who asked the question about the subcutaneous fentanyl. So she said, I meant the subcutaneous injection and not the transdermal route that forms a a depot. So I think for me it's all the same. Does it change for you guys? I mean,
yes. So subcutaneous, some of the palliative patients that are requiring high doses of opioids and are being managed at home, subcutaneous delivery routes in form of subcutaneous pumps are used, both for hydromorphone and fentanyl. So the subcutaneous absorption is almost similar to IV. So if you have to keep these patients in the hospital for IV management, these patients can be sent home with almost like an on-cue pump that you use for peripheral pumps. So it's an elastomeric pump. They can be sent home with sub-Q dosing of fentanyl or dilaudid. So it has been done in by palliative teams. It has good bioavailability. It's not similar as the depot fentanyl transdermal. It is sub-Q's bioavailability is almost similar to IV.
For both the things, actually in the Indian setup, the home care setups are not so good as compared to the other countries. So if the patient is in the hospital, definitely we can go for the parenteral preparation if the patient is not able to take the oral morphine. But in certain cases where there is attendants are saying that they don't want to go for any PICC line insertion and there is edema for that patient, subcutaneous route, this morphine or fentanyl can be used. I have used subcutaneous morphine on a 12-hourly basis. It works good. But for the home care setting, use of pumps is not very commonly used in the Indian scenario. And for the second question, the brachial plexus involvement usually occurs in the CA lung cases. Recently, I did a case of a CA esophagus who has this brachial plexus involvement plus the lymphedema in the upper in the arm. So one thing, a surface procedure which can be done, you go for a recent MRI scan, you see whether your needle will go through the trajectory of the tumor or not. And if you are well versed with the procedure, you can introduce the needle just near to the brachial plexus, and you can give daily installation of ropivacaine and dexamethasone so that local inflammation can be reduced. And the sensitization which is occurring from the periphery through the spinal cord to the brain, that spontaneous firing which is occurring at each and every minute can be stopped. So this has helped apart from the dose titration, as ma'am said, and the neuropathic medication. So this intervention I have used in many patients, and this helps. I'm not saying that it gives 100% relief, but it helps, and other things have to be continued. Over to you.
Great. So I think brachial plexus has always been difficult to manage, whether it has been an avulsion or whether it's because of the cancer. So it's been an enigma, and it's not going to go anytime soon. So guys, this was it. I think before we close, I just want to ask one thing. Dr. Taruna, what is the situation in your place? In India, more and more, like Dr. Sunny mentioned, that you have to take care of the symptom itself as well. And especially in Mumbai, we find oncologists telling us that there's very few referrals for procedures. They usually will refer the patient more, with a palliative intent in terms of symptom management rather than intending for a procedure. And procedures are usually looked down upon. So, what is your take on this? As far as in your place, is it more accepted by the oncologists and oncosurgeons? And second question is that what about the integration of the palliative care and the pain? So does the pain guy do all the home care and the palliative care, or it is like what Dr. Sunny said, that once patient comes to you, you have to manage everything, and that's not probably what I practice, I usually have a different guy who does palliative care, and we work as a team. So how does it happen in your place?
So it's a wonderful question, both of them. So regarding the oncologist, I work in Cook County Hospital. It has a huge oncology program. So it was I would say not even 10, 15 years ago, it was hard. It was similar that the oncologists wanted to hold on to their patients, take care of the pain medications themselves, even the opioids, they are well versed with the opioids. And then they hold on to the patient till the patient is a candidate for chemo or radiation. And then the patient is transferred over to palliative team. But over the last 10 or 15 years, with constant education, we have multidisciplinary meetings almost on a regular basis, on a weekly basis with the oncology palliative team on board. So we have tried to educate them regarding the options that are available. So now we are seeing more and more patients being referred early on for celiac plexus blocks, for hypogastric plexus blocks, even for intrathecal pump implantation. It has become much more of a normalcy. Certain oncologists who are from, I would say, old school, they still do not refer the patients. They do not believe in interventions, but more and more oncologists are actually referring the patients for interventional procedures. And we see a better, there are patients who have been told that your life expectancy is 4 or 5 months. And then there are patients with intrathecal pump that we have implanted who we are following for almost 2 years and longer, who actually, I feel that their quality of life improves when you are putting these, when you are doing these interventions at an early stage than at a later stage. The palliative team, we have a palliative team, which is internal medicine palliative trained physicians. So we work with them. They will do most of the symptom management, and pain management will still be with the pain management physician. So although these both teams do everything, if the patient is not following with palliative, we will make sure that we are giving something for constipation. We are making sure that we are giving something for vomiting, for appetite. If the patient comes to us, we are not going to refuse the management or symptom management, but definitely there is a palliative team that follows the patients in home hospice to provide them comfort care.
To add, Siddharth?
Yeah, sure, go on.
Like I am working in a purely onco institute. So
You started it there when they put the first post. I think you started the department, right?
So at the South Delhi branch, not the main branch.
Yeah. I saw the advertisement when it was put. Then I have been following that through.
Just
so,
near AIMS.
Yeah, I that time I was looking for, when this was almost 1 or 2 years after I came to Mumbai, and I saw that this will be a very good opportunity for somebody who wants to go in cancer pain. And I see that you have flourished like anything.
Actually, I have done my DNB also from Rajiv Gandhi Cancer Institute main branch.
Home ground, home turf.
Home ground, definitely. So you will get 2-3 scenarios. First scenario is like you must be getting patients who are ongoing their treatment, and especially the visceral malignancy, or if the tumor has metastasis to the bone, especially the vertebrae. So the patient has been referred to you for the pain management because the vascular, despite the titration done by the oncologist, is not getting the pain relief. So this is one scenario where you are giving these blocks and you are titrating the dose of morphine and again sending the patient to the medical oncologist so that they can.
I mean, how common is that?
Time लगता है लेकिन अब common हो गया है.
Yeah, so because I find in my practice, it's very uncommon. Most of these patients who, initially, like I saw one patient, which was I will call that as a pity patient. So maybe, they send on the last day of their discharge from the hospital, they will just put a reference, and then you go there and you see that everything has been prescribed, and you ask the patient, do you have any pain? And he says no. And then after that, it's quite I would say it's a demotivating thing, or like a demeaning thing for me to go there and then just diet a city or do my initials and then just leave from there. So the thing is that it definitely is going to take a lot of time, and I'm sure we'll figure out some way to help the patients. But by the time the patient is referred, I have seen patients who are, now in probably they have got some few days to live and all, and then we get the reference, and then we are supposed to do a celiac plexus neurolysis in that patient who is maybe not even able to lie supine, let alone prone. So that's the challenge, and it's all, unfortunately, it's coming from big institutes and oncologists who are being trained at premier institutes of the country like Tata. They are having these conceptions, and I think it will take a lot of
Definitely,
time.
it will take time, and time is changing.
Yeah.
So coming back,
is there an inpatient service that the pain physicians follow? So we have a pain clinic and we have our procedure rooms in the pain clinic, but we do rounds on the inpatient because we get a referral from all the different services. So I think that's where most of the cancer patients are picked up, on inpatient rounds. And when you talk to the patients and their families regarding the options that are there, the patients are the ones who drive it, compared to just talking to the oncologist and trying to pick up patients from the clinic. Once the patients are admitted with severe pain, that is the time to bring up these options, and those patients are more willing to go with those options.
But it becomes a conflict of interest once you are offering a palliative chemotherapy as an option for pain relief. And then the oncologist is going to tell you as a patient, my oncologist tells me that, do you want to target the tumor and reduce the size and then get the pain relief, or do you want to block the nerve and then you get the pain relief? So what do you choose? So it becomes quite challenging to negotiate this bouncer. So
I think it's a matter of education and working with the oncologist. The more and more we do it, that's the only way. Because if the oncologist is starting chemotherapy, they will actually call us to do the block before the labs are haywire. So they call us, can
that's
we do
what it should be done. Yeah, of course.
before we start the chemotherapy? So we try to accommodate those patients right away. And that's where I think the challenge is to inform the other services that the quality of life is also important. With treating the cancer, it is really important to provide a quality of life, not minimally improve quality of life, but quality of life as a human being. I think it is something that the concept has to change. It is going to take a while. I still see a lot of oncologists who hold on to their patients and don't want anything done.
Great. So thank you guys. Thank you so much for such an interesting and thought-provoking discussion. Especially we got to know about the other part of the world as well. The problems are not much different, only we are at a different timeline. So that's, yes. So I think we'll take it on from there. So thank you for the interesting discussion. So we'll now just end the session. Towards the end, as always, this is the season 2, and we are focusing on the cancer pain and chronic abdominal pain. So I thank today's speakers, Dr. Maitri, Dr. Namrata, and also today's faculties, Dr. Taruna and Dr. Sunny, for such an excellent discussion. So this is the season 2, and we have come up with a new time. So guys, it's 9:30 p.m. Earlier we used to do it at 7. And we have grouped up the topics. We have got 2 faculties, 2 papers, and of course, we'll be circulating the papers in advance. The next steps, they are important because the secret of getting things done is to act. So guys, just join our mailing list. Those of you who are new for the first time or will watch it later, most of our content is watched later on Facebook as per the past trends, or on YouTube later on. So just join our WhatsApp group. The link is already there in the chat or in the email. If you can't find anything, just drop in your suggestions, comments to me on mumbaiPainSchool@gmail.com. And just gear up, guys, for our upcoming hands-on workshop, cadaveric workshop, from 16 to 18 September in Mumbai. And this will be the 4th of its kind, which we'll be conducting. So thank you all for joining in. And I'll just now stop my screen share and we'll end the session. Thank you, guys. Bye-bye.
Thank you.